there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here at this institute, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some useful tips which may prove handy in your line of duty. So I welcome you to part 78 of our Pharmacotherapy MCQ series, which majors in toxicology. Our first question reads, Master ABC, a 3-year-old boy, is rushed to your accident and emergency department following an accidental ingestion of an unknown quantity of his grandfather's atenolol tablets. My question to you is, which of the following should the clinical team at the accident and emergency department factor in to ABC's management? Should it be timing of ingestion, hypotension, whether it is a hydrophilic or a lipophilic agent, or beta receptor selectivity of the drug overdosed? I'll give you 10 seconds to choose the correct answer. So here both answers A and C are correct. Now, I'd like to start by saying that multiple or many factors influence the therapeutic decision in a beta blocker overdose, with most common ones including, for example, the timing of ingestion, the formulation, that is whether it's extended release or immediate release, and whether the agent is hydrophilic or lipophilic. Now, I'd like to also add that activated charcoal can be considered in an overdose of an immediate release agent, but it isn't likely to be useful 2 hours after ingestion, or in the case of long-acting, that is the extended release or the sustained release beta blockers. Now, I'd also like to add that hemodialysis can be helpful with toxicity when the beta blockers are hydrophilic in nature, for example atenolol and even nadolol. Now, in beta blocker overdose, beta receptor specificity becomes less reliable and it is lost. The higher the dose or the greater the toxicity, the less reliable it becomes. Then I would like to add that toxicologic effects of beta blockers include, for example, bradycardia. They can cause hypotension with or without hypoglycaemia. It may be challenging to differentiate beta blocker toxicity from calcium channel blocker toxicity unless there is an empty bottle or unless hypoglycemia is present, because we know that the calcium channel blockers may cause hyperglycemia while the beta blockers cause hypoglycemia. So you can use that to differentiate the two. Let's move to the next question, please. And it reads, which of the options listed below most accurately classifies the pathway of digoxin elimination from the body? Is this drug a CYP3A4 substrate? Is it a CYP3A4 inhibitor? Is it a P-glycoprotein substrate, or is it a CYP3A4 inducer? I'll give you 10 seconds to choose the correct answer. It is a P-glycoprotein substrate. Now, Digoxin is a major substrate of the P glycoprotein, which is that protein is an efflux cell membrane transporter that is known to flush out or kick out drug from the cell. Now, there is a large number of inhibitors of the P glycoprotein which cause clinically relevant drug-drug interactions with digoxin. So be very careful when they are co-administered with digoxin in this very delicate population. Now, I would like to add that P glycoprotein inhibitors, like for example the protease inhibitors used in HIV management, and if I remember well, amiodarone, diltiazem, and even verapamil, can all increase digoxin serum levels. So be very careful when they are co-administered with digoxin, because severe toxicity would occur if the serum levels are elevated. Let's move to the next question, please. And it reads, as the clinical pharmacist based at the accident and emergency department, you are counseling a mother who is concerned about her daughter's ingestion of organic mercury compounds, specifically methyl mercury, which is a potential contaminant in seafood. My question to you is, which of the symptoms listed below would be concerning for methyl mercury toxicity? Would there be fatigue, tremor, acute GI distress, or ataxia? I'll give you 10 seconds to choose the correct answer. So all the answers there are correct. I would like to start by saying that organic mercury compounds can cause CNS toxicity. Now, while some other organ systems are involved, the GI, the respiratory, and even the renal, the predominant effects are neurological. Now, organic mercury and elemental mercury compounds produce acute neurologic toxicity, whereas inorganic mercury doesn't generally produce acute neurologic toxicity. Mark that difference. Now, pregnant patients, I would just like to warn you, should be counseled to avoid consumption of large predator fish due to the risk of ingestion of methyl mercury. Then I would also like to add that DMSA, which is Saxima, is the chelator of choice for early management of organic mercury toxicity. Then BAL, British anti-lewisite, which is also called dimercaprol, should be avoided since it can increase brain concentrations of mercury when used for organic mercury toxicity. Choose your antidote wisely. Let's move to the next question. And it reads, which of the treatment options listed below isn't appropriate for the management of tricyclic antidepressant toxicity? Is it hypertonic saline, hemodialysis, sodium bicarbonate, or lipid emulsion therapy? Hemodialysis it is. Now, hemodialysis isn't recommended in TCA toxicity because they all have very large volumes of distribution. That is to say, they distribute highly into the tissue and they don't remain in the blood. Now, the volume of distribution of amitriptyline, for example, is 18 to 22 liters per kilogram, as compared to gentamicin, for example, which is around 0.25 liters per kilogram. So you can note the difference there. Now, I would like to emphasize that medications with large volumes of distribution are more difficult to remove via hemodialysis. They are less dialysable. Now, lipid emulsion therapy creates a lipid sink and is effective in TCA toxicity since most of these drugs are lipophilic and they also have large volumes of distribution. Then hypertonic saline can also be used to manage refractory cases of malignant ventricular dysrhythmias caused by tricyclic antidepressant toxicity or where the pH is already at goal. Sodium bicarbonate, on the other hand, can be used to effectively manage patients with malignant ventricular dysrhythmias from tricyclic antidepressants. Now, the volume of distribution is the estimated volume or size of a compartment needed to account for the total amount of drug in the body, assuming it were present throughout the body at the same concentration found in plasma. In a nutshell, that is what the volume of distribution is. Let's move to the next slide, please. And the question reads, which of the metals listed below can be chelated by desferoxamine during toxicity? Is it iron, lead, aluminum, or arsenic? I'll give you 10 seconds to choose the correct metal. So both B and C can be chelated by it. Now, there are numerous chelating agents available with several being able to chelate different metals. Now, desferoxamine is a chelator of choice for both iron and aluminum. And lead, on the other hand, is chelated by calcium EDTA, whereas arsenic is chelated by dimercaptan or saxima. Now, just as a by the way, I would like to mention that the ferripron and the ferrosirox are oral ion chelators, but they are not used in the management of acute ion toxicity. Now, I'd like to also emphasize that aluminum toxicity can occur in patients receiving blood irrigation for hemorrhagic cystitis, so just be very cautious when managing such patients. Let's move to the next slide, please. And it reads, which of the clinical factors listed below shouldn't be taken into consideration in cases of digoxin toxicity? Is it a narrow therapeutic window or index? Is it a CYP3A4 substrate? Is it large volume of distribution or long half-life? I'll give you 10 seconds to choose the correct answer. So B it is. Now, digoxin has a large volume of distribution, which is around 7 liters per kilo. It also has a long half-life of about 36 hours. Then it has a narrow therapeutic index or window of 0.8 to 2 nanograms per ml. And it is a major substrate of the P-glycoprotein and not a CYP3A4. So that makes B the correct option in this case. And I would like to add that digoxin doesn't stay in blood and predominantly distributes into muscle, predominantly the myocardium, and it takes 4 to 6 hours to equilibrate in this particular tissue. Just as a by the way, let's move to the next question, which reads, Master HKR, a 2-year-old boy, is rushed to your accident and emergency department following ingestion of an unknown quantity of clonidine 0.1 milligram tablets. His mother found him unarousable next to the empty clonidine bottle, which belonged to this boy's elder sister, and she takes it for AHDH. Now, Master HKR was last seen 30 minutes prior to this incident, and he now has a GCS score of 5 and a heart rate of 60. The blood pressure is 110 systolic, 60 diastolic, and the SATs are 94% on room air. So my question to you is, which of the treatment options listed below would be the most appropriate in this clinical scenario? Would you administer Flumazenil at a dose of 0.01 milligrams per kilo IV stat? Would you administer epinephrine at a dose of 0.01 milligram per kilo IV stat? Or would you administer 0.02 milligrams of atropine per kilo IV stat? Or would you orally administer activated charcoal at a dose of 1 gram per kilo stat? I'll give you 10 seconds to choose the correct answer. Atropine at a dose of 0.02 milligrams per kilo IV stat would be our best bet in this particular case. Now, clonidine overdose manifests as hypertension and tachycardia in the hyperacute phase, and that is quickly followed by bradycardia, altered mental status, and hypotension. Now, there is no specific reversal agent or antidote therapy for clonidine, unfortunately, and therefore, in my opinion, general supportive measures are first line, and that includes the ABC: airway, breathing, and circulation. Master HKR's heart rate, even while asleep, under normal circumstances, should be 80 to 120. Therefore, this rate that they quoted up, which is 60, is or can be considered bradycardic and is consistent with the toxidrome predicted in such cases of toxicity. And therefore, atropine would be the most appropriate agent at this time. Now, epinephrine may be another alternative. However, these kids' blood pressure for the age group is within normal limits. Therefore, epinephrine isn't ideal. Now, while this is certainly a life-threatening overdose, activated charcoal isn't appropriate at this time because Master HKR has a questionable mental status that does not admit charcoal administration, and there is a risk of aspiration here. It's pretty high. Now, if the patient has a protected airway with, for example, endotracheal intubation with a cuffed endotracheal tube, then it would be reasonable to administer activated charcoal. And Flumazenil, on the other hand, is only indicated for benzodiazepine overdose, so it would be relevant in this case. And I would just like to caution you that in this population, clonidine can be considered, in quotes, a one pill can kill in this pediatric exposure. Now, one tablet of a typical adult dose can lead to a fatal overdose in children, so be very careful. Now, a large dose can cause hypotension, bradycardia, altered mental status, and continue exposure to this product can progress to respiratory depression and even refractory bradycardia, hypotension, and in extreme cases even coma can arise. So be very careful and deal with the toxicity as soon as you can. I would just like to remind you of the pharmacology that clonidine is a central alpha-2 agonist. Now, the alpha-2 receptor is presynaptic in nature. Therefore, clonidine causes positive feedback leading to decreased norepinephrine release. Now, in overdose, clonidine exerts peripheral postsynaptic alpha agonist effects as well. Let's move to the next slide. And the question reads, TKP was in a house fire, and this gentleman now complains of weakness, headache, dizziness, and abdominal pain. So my question to you is, Which of the antidotes listed below should Mr. TKP receive emergently as soon as possible? Should it be glucagon, diphenhydramine, amyl nitrite, or sodium thiosulfate? I'll give you 10 seconds to choose the correct answer. This patient should receive both amyl nitrite and sodium thiosulfate. I would like to start by saying that the common or the most common cause of cyanide poisoning is smoke inhalation that can come from the combustion of products containing both carbon and nitrogen. Now, in cyanide poisoning, amyl nitrite and sodium thiosulfate are used to cause methemoglobinemia, which binds to cyanide, and then the sodium thiosulfate can convert cyanide to thiocyanate for elimination through urination. Now, diphenhydramine is used for the reverse of antipsychotic induced neuroleptic malignant syndrome, so it's irrelevant in this particular case. Then glucagon is an antidote for beta blocker and calcium channel blocker toxicity. It's irrelevant in this case. Then I would like to add that hydroxycobalamin binds to cyanide to become vitamin B12, and it has the benefit of not causing methemoglobinemia, unlike the amyl nitrite. So it would be a better antidote, though its administration and monitoring may at times be cumbersome. Let's move to the next slide. And it reads, Mr. ZO, a 47-year-old male patient, is being managed for lead encephalopathy in your medical ward using a combination of dimercaprol and calcium EDTA. My question to you is, which of the allergies listed below should we be cautious about when administering dimercaprol? Will it be milk allergy, seafood allergy, peanut allergy, or iodine allergy? I'll give you 10 seconds to choose the correct answer. Peanut allergy it is. Now, dimercaprol, which is 2,3-dimercaptopropanol, or British anti-lewisite, abbreviated as BAL, is a chelating agent used in the treatment of lead encephalopathy. It is only available as an intramuscular injection with peanut oil as the vehicle used, since it's poorly soluble in water. Now, patients with a history of peanut allergy should have a risk-benefit analysis discussion with the healthcare provider regarding its use to avoid complications arising from the allergy. Let's move to the next slide, please. And it reads, which of the following treatments for hypoglycemia due to sulfonylurea toxicity requires glycogen storage to be present for its effectiveness? Is it octreotide, glucagon, 50% dextrose, or diazoxide? I'll give you 10 seconds to choose the correct answer. Glucagon it is. Now, glucagon requires glycogen storage to be present in order for glycogenolysis and even gluconeogenesis to occur, and thereby raise glucose concentrations in blood. Now, diazoxide, which is marketed as Proclysem, that is alternative D, is an oral agent typically used to treat insulinomas, but can also be used in refractory cases of sulfonylurea toxicity. So it isn't the best alternative in this particular case. Now A, which is octreotide or sandostatin, is a semi-synthetic long-acting analog of somatostatin which blocks insulin secretion from beta cells. So it's not the correct answer either. Then in the absence of IV access for 50% dextrose, glucagon can be considered initially, but patient will become hypoglycemic again if we don't address the problem without a long-term solution to keep their glucose levels up. And I would like to add that glucagon has a fairly short duration of action, 60 to 90 minutes to be specific. Let's move to the next slide. And it reads, Mr. JKM, a middle-aged male patient, is rushed to your accident and emergency department following an overdose of 20 tablets of Nebulate 5 milligrams, that is nebivolol or bistolic. And the nurse attending to this gentleman does an EKG or an ECG. So my question to you is, which of the following would most likely be observed on Mr. JKM's ECG or EKG? Would it be sinus tachycardia? Would it be sinus bradycardia? Would it be bundle branch blocks? Or would it be a normal sinus rhythm? I'll give you 10 seconds to choose the correct answer. So both sinus bradycardia and bundle branch blocks are correct answers. I'd like to start by saying that bundle branch blocks and sinus bradycardia are more commonly seen with beta blocker toxicity. And I would like to emphasize that Nebulate or nebivolol is an oral beta-1 selective beta blocker, and it is lipophilic in nature. Now, normal sinus rhythm and sinus tachycardia are typically seen with the dihydropyridine calcium channel blockers like amlodipine, for example, or even nifedipine, but not with diltiazem and verapamil, which are non-dihydropyridine calcium channel blockers. Now, I'd like to repeat that common ECG changes with beta blocker toxicity include sinus bradycardia, PR prolongation, variable AV block, junctional rhythms, bundle branch blocks, and even a QRS interval prolongation. Now, sinus bradycardia, PR prolongation, variable AV block, junctional rhythms, bundle branch blocks, and QT prolongation are typically seen with the non-dihydropyridine calcium channel blocker. So just mark the difference. It can help you in diagnosing what could have caused toxicity in a patient with these cardiac changes. Let's move to the next question, please. And it reads, DOP, a middle-aged patient, is rushed to your accident and emergency department by an ambulance. The nurse on duty is unable to fix an IV cannula, so you don't have IV access, and she cannot initiate IV therapy, so things are tough for this unconscious patient who has had sulfonylurea overdose. We are not able to infuse 50% dextrose here. Now, patient DOP's initial finger stick glucose reading is 22 milligrams per deciliter, pretty low. So my question to you is, which of the treatment options listed below would be the most appropriate for Mr. DOP now? Would you infuse IV dextrose 50%? Would you administer diazoxide? Would you administer glucagon? Or would you opt for activated charcoal? I'll give you 10 seconds to choose the correct answer. I would choose to administer glucagon. Now, glucagon administered intramuscularly or subcutaneously can be considered initially if IV dextrose can't be administered, like in this case of this patient, without IV access. Now, alternative B, diazoxide or proglycem, is an oral agent typically used to treat insulinomas, but may be used in refractory cases of sulfonylurea toxicity. So it isn't first line here. Now, alternative D, activated charcoal, should only be used within 1 hour of confirmed sulfonylurea ingestion. And another condition should be if the airway can be protected, or if the patient isn't actively vomiting or nauseous, and if there is no evidence of GI obstruction or a risk of perforation, because this would complicate issues. Now, if no IV access can be obtained for IV dextrose administration, glucagon can be considered initially, but the patient will become hypoglycemic again if we don't seek a long-term solution to keep his serum glucose levels up. So pay close attention to that and address the problem. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. Thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support, and even the kind collaboration, and I look forward to interacting with you in part 79 of this series. Thank you very much.